Cardiac disorders in pediatrics, left to right shunts. These are atrial septal defects, ventricular septal defects, and persistent ductus arteriosus, ASD, VSD, and PDA. First, we'll be looking at atrial septal defect. There are two main types of ASDs. There's a secundum ASD, which accounts for 80% of ASDs, and a partial AVSD. So it's either known as AVSD or a primum ASD. Both present with similar symptoms and signs, but their anatomy is quite different. The secundum ASD is a defect in the center of the atrial septum involving the foramen ovale. Partial AVSD is a defect in the atrial ventricular septum and is characterized by number one, an interatrial communication between the bottom end of the atrial septum and the atrial ventricular valves, which is known as a primum ASD. And number two, an abnormal atrioventricular valves, with a left atrioventricular valve which has three leaflets and tends to leak, known as a regurgitant valve. Clinical features of atrial septal defect. Symptoms. Most commonly, no symptoms. Other than that, you could have recurrent chest infections or wheeze, and also arrhythmias, but from the fourth decade onwards. Physical signs include an ejection systolic murmur, best heard at the upper left sternal edge, due to increased flow across the pulmonary valve because of the left to right shunt. A fixed and widely split second heart sound. It is often difficult to hear due to the right ventricular stroke volume being equal in both inspiration and expiration. With a partial AVSD, an apical pansystolic murmur from atrioventricular valve regurgitation. Investigations. These include chest radiograph, ECG, and echocardiography. For chest radiograph, the chest radiograph shows cardiomegaly, enlarged pulmonary arteries, and increased pulmonary vascular markings. ECG for secundum ASD, which is the more common one, the one with 80% of ASDs, partial right bundle branch block is common but may occur in normal children. Right axis deviation due to right ventricular enlargement. For partial AVSD, a superior QRS axis, mainly negative in AVF. This occurs because there is a defect in the middle part of the heart, where the atrioventricular node is. The displaced node then conducts to the ventricles superiorly, giving the abnormal axis. Echocardiography. This will delineate the anatomy and is the mainstay of the diagnostic investigations. Management of ASDs. Children with significant ASD, large enough to cause right ventricular dilation, will require treatment. For secundum ASDs, this is by cardiac catheterization with insertion of an occlusion device. But for partial AVSD, surgical correction is required. Treatment is usually undertaken at about 3 years to 5 years of age in order to prevent right heart failure and arrhythmias in later life. Now we're done with ASDs, we'll be looking at VSDs, ventricular septal defects. VSDs are common, accounting for 30% of all cases of congenital heart disease. There is a defect anywhere in the ventricular septum, perimembranous, which is adjacent to the tricuspid valve, or muscular, completely surrounded by muscle. They can most conveniently be considered according to the size of the lesion. Small VSDs. These are smaller than the aortic valve in diameter, perhaps up to 3 millimeters. Clinical features of VSDs include symptoms, asymptomatic. Physical signs, loud pansystolic murmur at left lower sternal edge. Loud murmur implies smaller defect. Quiet pulmonary second sound, which is the P2. Investigations, chest radiograph will be normal, ECG will be normal, echocardiography demonstrates the precise anatomy of the defect. It is possible to assess its hemodynamic effects using Doppler echocardiography. There is no pulmonary hypertension. Management of small VSDs. These lesions will close spontaneously. This is asserted by the disappearance of the murmur with a normal ECG on follow-up by a pediatrician or pediatric cardiologist and by a normal echocardiogram. While the VSD is present, prevention of bacterial endocarditis is by maintaining good dental hygiene. Now we're done with small VSDs, we'll be looking at large VSDs. Large VSDs. These defects are the same size or bigger than the aortic valve. Clinical features include symptoms, heart failure with breathlessness and faltering growth after 1 week old. So you need to remember the symptoms of heart failure. Recurrent chest infections. Physical signs include tachypnea, tachycardia, and enlarged liver from heart failure. An active precordium. Soft pansystolic murmur or no murmur, implying a large defect. Apical mid-diastolic murmur from increased flow across the mitral valve after the blood has circulated through the lungs. Loud pulmonary second sound, P2, from raised pulmonary arterial pressure. Investigations for large VSDs include, for the chest radiograph, you can see cardiomegaly, enlarged pulmonary arteries, increased pulmonary vascular markings, as well as pulmonary edema. In the ECG, you'll be able to see biventricular hypertrophy by 2 months of age. On the echocardiography, demonstrates the anatomy of the defect, hemodynamic effects, and pulmonary hypertension due to high flow. Management of large VSDs. Drug therapy for heart failure is with diuretics, often combined with captopril. Additional calorie input is required. There is always pulmonary hypertension in children with large VSDs and left to right shunt. This will ultimately lead to irreversible damage of the pulmonary capillary vascular bed, known as Eisenmenger syndrome. To prevent this, surgery is usually performed at 3 months to 6 months of age in order to, number 1, manage the heart failure and faltering growth, and number 2, prevent permanent lung damage from pulmonary hypertension and high blood flow. Now we're done with ASDs and VSDs. We'll be looking at PDAs, persistent ductus arteriosus, also known as persistent arterial duct. The ductus arteriosus connects the pulmonary artery to the descending aorta. In term infants, it normally closes shortly after birth. In PDA, It has failed to close by 1 month after the expected date of delivery due to a defect in the constrictor mechanism of the duct. The flow of blood across a PDA is then from the aorta to the pulmonary artery, left to right, following the fall in pulmonary vascular resistance after birth. In the preterm infant, the presence of a PDA is not from congenital heart disease, but due to prematurity. This is described in Chapter 11. Clinical features of PDAs. Most children present with a continuous murmur beneath the left clavicle. The murmur continues into diastole because the pressure in the pulmonary artery is lower than that in the aorta throughout the cardiac cycle. The pulse pressure is increased, causing a collapsing or bounding pulse. Symptoms are unusual, but when the duct is large, there will be increased pulmonary blood flow with heart failure and pulmonary hypertension. The chest radiograph, so for investigations of PDAs, the chest radiograph and ECG are usually normal. But if the PDA is large and symptomatic, the features on chest radiograph and ECG are indistinguishable from those seen in a patient with a large Vsd. However, the duct is readily identified on echocardiography. Management of PDAs. Closure is recommended to abolish the lifelong risk of bacterial endocarditis and of pulmonary vascular disease. Closure is with a coil or occlusion device introduced via a cardiac catheter at about 1 year of age. Occasionally, surgical ligation is required.